Very good morning to all. I myself, Dr. Lens Paul. I am working as a consultant neonatologist at Mitera Hospital, Kottayam, Kerala. Today I will be going to talk on a very important topic in neonatology, that is enteral nutrition in preterm babies. It is a very relevant topic from a physician side as well as from a nursing side. So we will go to the topic proper. So what are the aims of nutrition in a preterm baby? Basically to meet the nutritional demands for the day-to-day living in a preterm baby and thereby preventing the various deficiencies and promoting growth in the baby. And definitely nutrition will be having a long-term impact on the growth and neurodevelopment in preterm babies, especially if you are providing proper nutrition. Definitely baby, the preterm baby will be having a better neurodevelopmental outcome as well as growth in the later life. So coming to the, what is the essential difference between a term and a preterm baby? What happens is that in a term baby, there is actually a smooth transition from the intrauterine to the postnatal period. By 40 weeks, the baby will be reaching the appropriate maturity, and thereafter, they will be moving to the postnatal period in a smooth way. Whereas in a preterm baby, any baby that is born less than 37 weeks is called a preterm baby. In those babies, we will actually have to provide the intrauterine milieu artificially after birth till the age of 40 weeks, and thereafter for the wait for the catch-up growth. So it is something very important in the case of a preterm baby. Another important hurdle in a preterm baby is that the suck-swallow coordination won't be that developed in a preterm baby. It is actually a complex developmental task. That coordination develops only once the baby reaches around 34 weeks of gestation. And basically, definitely the success basically depends on the various neurological, digestive, absorptive and the metabolic maturity in a preterm baby. Coming to the, as I already discussed, in a term baby, definitely the suck-swallow coordination will be properly developed, whereas in a preterm baby, the sucking reflex will be there by around 23 weeks, but the coordinated suck-swallow will be present only by around 34 weeks of gestation. So also the gastrointestinal motility will also be definitely different in a term and a preterm baby. What happens in a term baby is that there will be different better coordinated motility of the various parts of the bowel, whereas in a preterm baby, in stomach there will be gastric emptying will be prolonged. So also the intestinal as well as the esophageal motility will be very low in a preterm baby. What happens is that the preterm baby is in a physiological ileus stage when compared to a term baby. Coming to the various nutrients in detail, if you can see, first we will see about proteins. In adults, the adults will be able to digest around 95 to 100% of the proteins that are provided in the food, whereas in a newborn, whether it is a term or a preterm, that digestive ability will be very low. Only around 80% of the proteins will be absorbed in a preterm baby. This is basically due to the low enzymatic maturity in preterm baby, like various enzymes which metabolize the protein, that is the carboxypeptidases, chymotrypsin, etc. These are very low in a preterm baby. So definitely the protein digestion is affected in a preterm baby. When it comes to the fat also similarly, fat is the most poorly digested macronutrient, and in term babies around 85 to 90% of the fat is absorbed, whereas in a preterm baby only 50% of the fat that is provided in the diet is absorbed. This is also because of the various enzymes which are very low in activity in a preterm baby, like the lingual lipase, bile salt stimulated lipase, pancreatic lipase, etc. And so also when it comes to various components of lipids, the MCTs which are very easily digestible. But the sad thing is that most of the preterm formulas are very low in MCT. They are actually having more amount of long chain fatty acids. But now there are actually formulas which are coming up with more MCT based preparations. But still, definitely the bioavailability of fat is very low when it comes to a preterm baby compared to a term baby. So also the carbohydrates. Digestion is also impaired in preterm baby. Only 30% of the carbohydrates are digested when compared to those of a term infant. So also basically due to various enzyme low levels of various enzymes like the intestinal lactase, pancreatic amylase, etc. And most of the preterm formulas actually contain glucose polymers rather than lactose. Most of the preterm formulas contain low lactose. And these glucose polymers are mostly digested by an enzyme which is called alpha glucosidase. But this alpha glucosidase attain 70% maturity only between 26 and 34 weeks of gestation. So almost all the macronutrients absorption are impaired in a preterm baby. Now we will discuss regarding what is the energy requirement or what is the calorie requirement in a preterm baby. It is actually calculated by some formula, that is energy intake is equal to energy stored plus energy expended plus energy excreted. And the energy expended is actually calculated by the energy required for the base maintaining the basal metabolic rate, activity, thermogenesis and energy synthesis. So this is actually a table that is actually given in Fenner of Martin, which actually clearly differentiate the various calorie requirement for various things. Like say for example, for maintaining a resting metabolic rate, it requires around 40 to 50 kilocalories per kg per day, and activity around 5 kilocalories, thermoregulation around 5 kilocalories, and energy synthesis around 15 kilocalories, energy stored of around 20 to 30 kilocalories. Energy excreted is around 15 kilocalories per kg per day. So the total calorie requirement will come to around 90 to 130 kilocalories per kg per day. So this much amount of calories we will have to provide for the preterm baby for having a successful transition from the intrauterine to the postnatal environment. So there are some recommendations. We all know the apex bodies for nutrition, that is the AAP and the SFAGAN. AAP, the calorie which the requirement for a preterm baby is around 105 to 130 kilocalories per kg per day. Definitely SFAGAN usually gives a little bit more high cutoff. It is the calorie requirement for a preterm baby as per SFAGAN is around 110 to 135 kilocalories per kg per day. And especially preterm baby, especially SG or IUGR babies, they actually, it is not like SG or IUGR baby have very low requirement. They require actually energy which is more than that needed for a normal AGA preterm baby. So those babies also should be taken care of very carefully in the postnatal period. Now coming to the various sources, carbohydrates, what happens in a term baby, the main thing is that what is the amount of carbohydrate we will have to supply in our parenteral nutrition or in the breast milk. So what happens is that, how will we decide on that? So in a normal term baby, the amount of glucose that is produced by the liver, that is the glycogenesis, gluconeogenesis is around 3 to 5 milligrams per kg per minute. So definitely we will have to provide something around that for in a preterm baby for maintaining a smooth growth. So around we will have to provide a carbohydrates of around 5 milligrams per kg per minute. In an extreme preterm, if the requirements are even higher, around 8 to 9 milligrams per kg per minute. And next coming to fats. Fat part is something very important. So all the babies from day one, from all preterm babies from day one should be provided with fats. Actually, I know many units they actually don't give fats in TPN. So when we ask them, their response will be, if we give fats in TPN, there is more risk for sepsis. So we don't, in our unit we don't give TPN. So there is nothing like that. There is no much significance in giving partial parenteral nutrition. Definitely, we will have, if you are giving parenteral nutrition, it should be a total parenteral nutrition. Definitely, we will have to definitely maintain a non-protein calorie ratio between carbohydrates and fats. So if we start in a baby, we will start normally at a rate of around 0.5 to 1 grams per kg per day, and we will hide the fats by around 1 gram per kg per day and reach a maximum of around 3 to 3.5 grams per kg per day. So why is this fats is very supplementation is important. It is very important because fats are intralipid or the SMOF should be definitely supplied for a better neurodevelopmental outcome, better cell signaling and myelination in a preterm baby. Coming to the proteins also this is actually a table from Fenner of Martin. Proteins also there are various cutoffs, but it's very difficult to remember all these cutoffs. So if you ask me what is the protein requirement in a preterm baby, it comes around 3.5 to 4.5 grams per kg per day. So along with these macronutrients, definitely we need something which is called the micronutrients also. So how will you decide on the micronutrients? So these are some of the micronutrients, the various minerals like calcium, magnesium, phosphorus, iron, sodium, potassium, chloride. All of this should be supplemented in your enteral nutrition for a smooth outcome or a better growth. And definitely we should take care of the trace elements too, that is chromium, copper, fluoride, iodine, manganese, molybdenum, selenium, zinc, etc. So now actually we who are seeing NICUs, they actually have specialized TPN preparations which contain all these trace elements. But if you don't have that fortune, then you can actually will be preparing TPN by adding carbohydrates, that is 10% or 25% dextrose, then sodium, potassium, calcium, phosphorus, magnesium, amino acid in one fluid, and in the second line you will be giving the lipid plus the MVIs. So this is something very important. Proper preparation of the total parenteral nutrition is also something very important. So what are the goals of early intense nutrition? So what are the goals? So it's basically to promote the growth and nutrient accretion in a preterm baby comparable to that of a fetus of the same gestation age, and thereby avoiding the postnatal growth failure, and thereby minimizing, and at the same time you should take care of the various aspects like feed intolerance and incidence of necrotizing enterocolitis. So definitely early and intense nutrition definitely gives better neurodevelopmental and long-term health outcomes in a preterm baby. Definitely, as I already told, we should definitely take care of the various issues of immature gut motility and function leading to feed intolerance and NEC. So now we will come to a very important part, that is minimal enteral nutrition. So what is this minimal enteral nutrition or trophic feeding? So many of the ICUs, like say around 40 to 50% of the neonatal ICUs in India, it's like say if there is a 25-week or a 26-week baby which is being delivered, most of the unit what they do is just keep the baby NPO and start the baby on total parenteral nutrition. That should not be done. Whether it is a 24-week or 25-week or 26-week baby, definitely baby should be started on minimal enteral nutrition. Minimal enteral nutrition means we are actually just priming the gut with a very low volume of feed, like say around 20 to 25 ml per kg. So if it is a 1 kg baby, 25 ml per kg comes up around say 1 or 2 ml to hourly. So that means minimal amount of feed. So if it is a 500 gram baby, 1 ml or 2 hourly, that will be the amount which comes in minimal enteral nutrition. So depending on the unit protocol, all babies should be started on minimal enteral nutrition. So what are the advantages of minimal enteral nutrition? Definitely shortens the time to regain the birth weight, improves the enzymatic maturation and GI motility, improves feed tolerance, improves the mineral absorption and mineralization, and lowers the incidence of cholestasis. So any baby, whether it is a 25-weeker, 24-weeker, 26-weeker, all babies should be started on minimal enteral nutrition. And how to hike up the feeds is basically depending on your unit protocol. Whatever be your unit protocol, definitely all babies should be started on minimal enteral nutrition. So now coming to the choice of milk in minimal enteral nutrition. So definitely your first choice will be exclusive breast milk. And say 5 to 6 years prior, your second choice was formula. Now we have a bridge in between, that is called the donor human milk, and it is not just donor human milk, it should be pasteurized donor human milk. There can be a practice, I will just tell you. You have two babies lying side by side. One baby delivered today, that is a 26-weeker baby, and another is actually a baby who is 10 days old, it is a 28-weeker baby, and definitely that baby's mother will be having a better milk output. So what happens is the staff on duty, if the 26-week baby has no milk, so that staff will take the milk from the 28-week or 10-day-old baby's mother's milk to this baby. So is it a good practice? It is not a good practice, because that is, we are just taking the milk from the other baby to this baby. It is not treated or pasteurized. The disadvantage is that suppose that mother's milk has that mother is infected with HIV, CMV, etc. That infection get transmitted to this 26-week baby. It is actually a negligence. So definitely, if you are giving donor milk, definitely it should be a pasteurized donor human milk. And the third choice will be definitely formula. And next question will be, can MEN be given on ventilator or a CPAP? So what will be your answer? Whether the baby is on CPAP, ventilator, high frequency, whatever type of respiratory support, all babies, unless there is any contraindication, should be given minimal enteral nutrition. In the case of severe asphyxia, there are two exceptions. One is severe asphyxia, where you usually keep the baby NPO for around 6 hours, and asphyxia is a state, and after 6 hours we reassess the baby. If the baby is having no aspirates, no abdominal distension, baby has fast stools, bowel sounds are adequate, then you start the baby on feeds. And similarly, in babies whose antenatal Dopplers have absent or reversed interstitial flow, in those babies definitely the splanchnic circulation will be compromised. So in those babies also we usually give a initial window. Say in AEDF, in my unit usually we follow 6 hours, and RADF around 24 hours. So these are the two indications where we don't give minimal enteral nutrition. Coming to the initial method of feeding, this is actually a feeding protocol that is actually adapted from the All India Institute of Medical Sciences. The main thing is that feeding protocol we can't standardize for all NICUs. It is actually different for different NICUs, because sometimes your sepsis rate may be very high in your NICU. In such cases, you will have to rapidly progress the feeds. Sometimes your NEC rates may be very higher, so you will have to hike up the feeds very judiciously. So you can't standardize a feeding protocol for all NICUs. So depending on your circumstances, you can create your own feeding protocol and strictly follow the feeding protocol. So we'll just discuss the feeding protocol from the All India Institute of Medical Science. So if it is a less than 28-week baby, definitely the baby should be on minimal enteral nutrition and total parenteral nutrition. This is because there won't be any sucking efforts, and there is no propulsive activity motility in the gut. In the 28 to 31-week group, there might be sucking bursts, but there is no coordination between the suck solo and breathing. So definitely they should be given some sort of intragastric feeding, whether it is an orogastric or an nastrogastric feeding with occasional spoon or palate feeding. And in the 32 to 34 weeks group, they have slightly mature sucking pattern, and the coordination between breathing and swallowing begins. So those group of the babies whom we can give palate or spoon feed, and in more than 34 weeks, definitely the mature sucking pattern and suck swallow coordination will be there, so they can be directly started on breastfeeding. So this is actually in short. So if it is a less than 28-week baby should be on minimal enteral nutrition and TPN. If it is in the 20 to 31 weeks group, start the baby on intragastric feeding. Observe if the baby has any feed intolerance. If the baby has no feed intolerance, continue the intragastric tube feeding till 32 weeks. If there is any issue of feed intolerance, then you can keep the baby NPO for some time and start the baby on parenteral nutrition. I will be discussing this later. In the 32 to 34 weeks, if the baby is tolerating palate feeds, definitely continue. If not, then start the baby on orogastric or NG feeding. And if the baby is more than 34 weeks, direct breastfeeding. If not tolerating, give the baby palate feeds and direct breastfeeding in between. So the initial method of feeding. So I will give you a scenario. We have two babies. One is a 35-week baby, 1 kg baby, and a 35-week baby, 2 kg baby. So your staff may be asking, sir, this is actually 1 kg baby. How can we start the baby on direct breastfeeding? Definitely that baby should be started on direct breastfeeding because it's not the weight, it's actually gestation which actually decide on the feeding ability. So that is the first thing which you should be noted. And not all infants born at a particular gestation would have the same feeding skills. That's also very important. And any baby more than 34 weeks, definitely baby should be given on direct breastfeeding or nutritive sucking. And if it is less than 34 weeks, that is especially in the 32 to 34 weeks, we should provide something which is called non-nutritive sucking or NNS. So how will we do this non-nutritive sucking? So in 32 to 30, we do it in a 32 to 34 weeks group. So how we do is, we at the time, just before the time of feeding, we pump the milk from the mother's breast, keep it aside, and then we will allow the baby to suck on the empty breast for some time, and thereafter we will give the feed through the spoon feed or the intragastric route. So we should not be done. It should not be done in the reverse way, like first giving the feed and then trying to do suck the baby, allow the baby to suck on the empty breast. It should not be done like that, because once you give the feeds, the hunger will be satisfied and baby won't be sucking on the empty breast. So it should be done before the feeding is given on the empty stomach. That is called non-nutritive sucking. It is basically improve the suck-swallow coordination in a preterm baby. So we will be discussing on the steps of giving a Parada. I think most of you might be giving Parada feeds. You might be monitoring how to give Parada feeds. So briefly on to the steps. So to place the infant in the upright posture on mother's lap. Second point is, keep a cotton napkin around the neck to mop the spillage. Third thing is, take the required amount of express breast milk by using a clean syringe. For this, fill the Parada with milk short of the brim. Fifth, hold the Parada from the sides, do not put your finger. And sixth, place it at the lips of the baby in the corner of the mouth. That is something very important. We should not be forcing through the middle of the mouth. That is something very important. And the tip the Parada to pour a small amount of milk into the infant's mouth. And feed the infant very slowly. He or she will actively swallow the milk and repeat the process until the required amount has been fed. If the infant does not actively accept and swallow, sometimes the baby might get into sleep. Try to arouse him with a gentle stimulation. And next point is, the 11th point is the most important thing. While estimating the milk intake, definitely you will have to take care of the amount of milk that is left in the cup and the amount of spillage. And the 12th point is very important. All mothers should be given proper education how to sterilize your Parada. It's not like just soap and water washing will sterilize the Parada. Definitely you should wash the Parada with soap and water, and you should put in a boiling water for around 20 minutes to sterilize before the next feed. So coming to the intragastric type of feeding, that is especially done in babies in the 28 to 31 weeks group. So there are two ways to give. Either you can give the baby through a nasogastric tube, or you can use it through the orogastric route. So which is better? Definitely it is the orogastric route which is better, because nasogastric feeding actually increases the airway impedance and the work of breathing in a very preterm infant. So it is the orogastric tube feeding which is the most preferable one. And now coming to the two other things, what is the intermittent versus continuous feeding? So most of the NICU, say around 80 to 90% of NICU might be doing intermittent feeding. Intermittent bolus feeding meaning you will give the required amount of feed over a period of 10 to 15 minutes. Then you will keep the baby, give the baby rest for the next 2 hours, and then again give the bolus feed in 10 to 15 minutes. That is the intermittent or the bolus feeding. Whereas in a continuous feeding, you will be giving it through a syringe pump or an infusion pump. Like say if you are the baby is giving 20 ml feed, then that 20 ml feeds will be given over a period of 2 hours. That is 20 divided by 2, so around 10 ml per hour. That will be the rate. So most of the studies actually show there is no much difference whether it is an intermittent or a continuous feeding. There is no much difference in the time to reach full feeding or somatic growth, and the incidence of NEC was not much different between the two groups. The only major disadvantage with the continuous feeding is that you are actually using an infusion pump. So what happens is the fat particles will stick onto the syringe and tubings during this continuous feeding, resulting in a significant loss of energy and fat content during continuous feeding. So if you ask me which is a better method, definitely it is the intermittent or the bolus feeding which is better. So now coming to the steps of intragastric tube feeding. So what are the steps of giving intragastric tube feeding? So first step is, before starting a feed, check the position of the tube. So that is something very important. You might have already put a orogastric tube, so you might have given a feed 2 hours prior, but still definitely you will have to check the tube position before each feed. Remove the plunger of the syringe. Connect the barrel of the syringe to the end of the gastric tube. That is something very important. You should not be like you connect the syringe to the tube and then remove the plunger. No, the plunger should be removed first and then attached to the barrel of the syringe to the end of the gastric tube. Then pinch the tube and fill the barrel of the syringe with the required volume of milk. Hold the tube with one hand, release the pinch and elevate the syringe barrel. And sixth point is very important, let the milk run from the syringe to the intragastric tube by gravity. You should not insert your plunger back and push the milk through the intragastric tube. You should allow the milk to flow through under the effect of gravity. Control the flow. You can actually control the flow of the milk by elevating or lowering the syringe. If you are elevating, definitely the milk will flow a little bit faster. If it is you are lowering, definitely the milk flow will be decreased. And it should take around 10 to 15 minutes for the milk to flow into the infant's stomach. Observe the infant during the entire gastric tube feed. Do not leave the infant unattended. Stop the tube feed if the infant shows any of the following signs like breathing difficulty, cyanosis, becoming floppy, vomiting, etc. And 10th point is something very important. Cap the end of the gastric tube between feeds. Suppose the baby is on CPAP, you cap the tube for half an hour and then keep it open for the next 1.5 hours. And avoid flushing the tube with water or saline after giving feeds. You shouldn't do any saline or water flush of the tube after giving feeds. So we'll just skip this slide. And so as I have already discussed, your choice of milk will be express breast milk in a preterm baby. All babies should be on exclusive breastfeeding. Second choice will be pasteurized donor human milk. Third choice will be formula, and only if the breast milk or donor milk is not available. And how much? So now we will be seeing the amount of milk that should be given to a preterm baby. It is basically decided based on the insensible water losses, various other losses, and urine output. Say for example, it is compared to babies 26 weeker and 34 weeker. So in a 26 weeker baby, the stratum corneum, the skin layers will be very less in number. There is only around 3 to 5 layers will be there, whereas in a term baby, there will be around 20 layers of stratum corneum. So what happens that the evaporative water losses from the skin will be very high in a 26 weeker or extreme preterm baby compared to that of a term baby. So definitely the fluid requirement in those babies will be very high. So this is actually a table which I took from Penrose Martin to calculate the requirement of fluid in a various babies. So if it is less than 750 gram, you will start a baby on 100 ml per kg per day. If it is 750 to 1000 gram, around 80 to 150. 1000 to 1.5 gram, 60 to 100. More than 1500, it is 60 to 80. But sometimes it will be very difficult to remember all this cutoff. So what in my unit, what I do is less than 750 gram, start at 100, 750 to 1000 gram, start at 90, 1000 to 1500, 80, more than 1500, 60. Easy to remember. Then you will hike the fluids by around 20 ml per kg per day till it reaches around 150 ml per kg per day. And next, coming to something which is called fortification of milk. It is something very important because you will have to actually provide a calorie of around 90 to 120 kilocalories per kg per day. So many a times you might not be able to provide that much amount of calories through milk alone. So in such cases, you will have to actually add some additional nutrients to the preterm mother's milk. So that is what is called human milk fortification. Classically we use a bovine milk based fortifier which is called the Lactodex HMF. This contains, the ratio of fortification is 1 gram of HMF to be added 25 ml of feeds. And when to start a baby on HMF is also something very controversial. There are even recommendations of starting fortification even from 50 ml per kg per day. But if you ask me, definitely you can start fortification once the baby reaches 100 ml per kg per day, or rather 100 to 150 ml per kg per day. And you should have to continue fortification of milk till the baby reaches 2.5 kgs. So, if the baby is on human milk fortifier, should we give calcium, phosphorus and various supplements? So that is something very important. If your baby is on a human milk fortifier, there is no need to provide additional calcium, additional phosphorus, additional zinc, additional multivitamin, additional vitamin D or additional folic acid. All these nutrients will be supplied with the help of a human milk fortifier except iron. But now the recent HMO formulation actually have a reasonable amount of iron too. So if at all needed, the only thing you will have to supplement is iron. So now we will go to something which is called some pathological aspects. So the baby is on full feeds, and now you will have to start a baby on, you will have to assess if the baby is actually having proper weight gain. So if the baby is not having any proper weight gain, what are things you will have to take care of? If the baby is on breastfeeds, see for the method of feeding, whether it is a correct positioning, correct attachment, and what the frequency of feeding, and whether it is, if you are actually giving 2 to 3 hourly feed, or you are actually even prolonging the duration like 4 to 5 hourly, and definitely you will have to take care of the night feeds. And if the baby is on palate or spoon feed, definitely incorrect method of feeding, due to excessive spillage, incorrect measurement or calculation, infrequent feeding, and not adding fortifier in the milk in VLPW infants. These are some of the reasons for inadequate weight gain in a preterm or babies on a palate or spoon feeds. And second thing is increased demands, especially due to some illness like hypothermia, cold stress, bronchopulmonary dysplasia, and especially if the baby is in the preterm baby, especially some babies might be on prolonged ventilator, might be requiring some sort of steroids. So those babies who are on corticosteroids also will be having inadequate weight gain. And various underlying pathological conditions like anemia, late metabolic acidosis, hyponatremia, late onset sepsis, feed intolerance, and exaggerated gastroesophageal reflux. These are some of the causes for inadequate weight gain in a preterm baby. So coming to my last part, so we will briefly discuss on feed intolerance. So you have started the baby on feeds, baby reached full feeds, now the baby develops some sort of feed intolerance. So how will you diagnose feed intolerance? So the main symptoms of feed intolerance are, one is vomiting, either altered milk, bile or blood stained milk, and we will be having some sort of systemic features like lethargy, apnea, etc. And the classical signs of feed intolerance are abdominal distension with or without visible bowel loops, increased gastric residues, that is more than 10 ml per kg or any change from the previous pattern, and abdominal tenderness, reduced or absent bowel sounds, and systemic signs like cyanosis, bradycardia, etc. So this is actually an algorithm for management of feed intolerance in a preterm baby. And before going in detail into the algorithm, I will be saying two important points. Never ever do pre-feed gastric aspiration. That is, there are some units may be actually doing too early pre-feed gastric aspiration. It should not be done. It is not a routine protocol. And just some clear aspirates or just one episode of vomiting is not a feed intolerance. These two things you should be taking care of. So if the baby has an increase in abdominal gut by more than or equal to 2 cm or altered vomiting, definitely aspirate the stomach contents. If it is a bile or blood stained aspirate or vomit, definitely you will have to withhold feeds for 24 to 48 hours, evaluate for systemic and the local causes and manage accordingly. If it is not bile or blood stained, if it is a clear aspirate, then you will have to see for the volume of the aspirate. So if the volume is more than 50% of the feed volume, definitely withhold 1 or 2 feeds. If the aspirate volume is 25 to 50% of the feed volume, reduce the next feed volume which is equal to the amount of aspirate volume. Suppose the aspirate you are giving 15 ml feed, you have 5 ml aspirate, definitely you will have to give 10 ml in the next feed. And if the aspirate volume is less than 2 to 3 ml or less than 25% of the feed volume, there is no need to stop the feeds. Definitely you can continue the baby on feeds. And now if the feed intolerance recurs once you have stopped the feed and again restarted on feeds, definitely you will have to assess for the clinical stability and evaluate for systemic signs. If there are no systemic signs and the baby is clinically stable, check the position of the orogastric tube. Try changing the infant position from the supine to the prone or right lateral decubitus. Withhold feed for 12 to 24 hours and reassess. And if there are systemic signs, definitely it is better to withhold feed for 24 to 48 hours and see for the various causes like NEC, sepsis, etc. and manage accordingly. This is actually a small algorithm for management of feed intolerance in preterm baby. This will be the very last slide of the presentation. So thank you all. Thank you for the patient listening, and thank you for giving me this opportunity to have a presentation in front of you all. And if you have any doubts, definitely you can ask me, or even you can message me through WhatsApp or Telegram. Thank you.